So anyway, we've been talking and we've been having a great conversation. And so the thing is, I want to give a chance for both of our guests to introduce themselves and just tell us a little bit about what they're doing in their roles currently. And then we'll launch into how we connected, the article that we connected over. So Earl, if you would, you could go ahead and kind of let us know who you are and what you do.
Sure, absolutely. My name is Earl Dalton, and I am the Chief Nurse Officer for Health Carousel, which is a contingent staffing-based firm here in Cincinnati, Ohio. We do serve all 50 states, and we have a fairly robust international program where we help bring international nurses from around the world into the United States to be helpful in communities. And so I feel incredibly blessed to be part of healthcare in this way. This is my 25th year in nursing, and I largely spent a lot of my time in the Duke University system, and then some in the Tri-Health system here in Ohio in various critical care sort of roles. And it's an honor to be here today. I'll turn it over to Ann.
Great. Ann?
Hi, I'm Ann Dapper Woods. I am the Chief Nurse of Walters Clore, the Health Learning Research and Practice Division, and I'm in charge of the nursing strategy and evidence-based practice for Walters Clore. We're a global information company. I've been a nurse for 37 years and a nurse practitioner since 1998. I still practice weekends for Penn Medicine Chester County Hospital as a critical care nurse practitioner, plus I do a little bit with primary care as well to keep up my dual advanced practice certifications. And then I also am adjunct faculty for Drexel University in their graduate nursing program. And like Earl, I feel really blessed to be here and be part of this discussion. Nursing is so important to me. And I think that we have a lot of things that we can change about who we are as a profession to help us move forward.
That's amazing. I'm so glad to have both of you here. I always think that every guest that I've had, I do not know, but we have a connection. I graduated from the University of Cincinnati with my NP, and Earl is in Ohio. And then for you, and my former nursing director that first got me into nursing education was Dr. Ruth Whitman Price, who worked at Drexel for many, many years and has published a lot with Drexel. Do you know Dr. Whitman Price? She's awesome, just amazing. So those connections are wonderful. So the article that kind of brought us together was one that you both worked on that talked about trends in nursing. And of course, because of Regis having baccalaureate nursing program as well as the graduate nursing programs, we're always interested in knowing where the profession is heading. So there were 10 different things you all talked about, all very interesting, but there were a couple that I really know that nurses in general probably will have conversations around. And so those are the ones I kind of want to talk about a little bit. And I'm going to start with you, and I'm going to talk a little bit about simulation. Now, I will tell you that when it comes to simulation, I've been a nurse for 15 years. And so when simulation started for me, we had for lack of a better word, they were the simulation dummies, is what we called them. And all I knew was they were heavy. They all looked alike, whether they were male or female. And you just put a wig on the male one and looked like, they were very rudimentary. What kind of advances have you seen come about? And what role do you think that's going to play for us, particularly now with COVID and some of the issues around finding clinical practice areas?
Well, I think simulation has really evolved, and especially in the last few years. And when we look at the impact of COVID, it really had to evolve in the last year. In graduate programs, we were using simulation where our students would come into the sim lab. We would teach them the skills of being an advanced practice nurse. But we also used, in our undergraduate program, we used a similar model, bringing our students in to the simulation lab, learning those skills to be a nurse. But simulation has gone beyond that, and now we're using simulation as virtual simulation, where they're actually doing, simulation work on their computers at home, and really their case-based scenarios. We also have AR and VR that have come into play that we didn't have, 10 years ago. So we're using that as well. And certainly what we're seeing is that simulation is starting to make the move from being education-based into the practice setting as well. so that we can really upskill the nurses who are working so that they're able to meet the needs of the patients that they're taking care of.
Yeah, it's definitely advanced. And Earl, have you had the opportunity with the nurses and the varied types of companies that you're working with healthcare-wise to interact with simulation or to have any feedback from that standpoint?
Well, and just the sort of piggyback, the advancements I've seen in that world are absolutely amazing. And so, nursing, I have always felt is sort of like SEAL team training, right? We train hard in our industry because we know the patients deserve that and the patients need that. And so I've been blown away certainly by the AI pieces, the introduction of Watson by IBM and et cetera, right? Even down through HealthStream and companies of that ilk, right, that are sort of learning management systems. Their ability to have their participants, take a series of tests and have the system, right, I'm air quoting here, right, pick out trends and deficits and help people reinforce exactly where the learning needs to be, rather than some measure of content that you didn't need because it turned out you knew those pieces. I've been blown away by that. So yeah, the advancements certainly down the AI road, I would expect to continue. I think they're incredible.
As you all are talking, I'm thinking too that, a lot of times when we talk to people that are already in practice, old school nurses like us, they will say, well, there's no substitute for the patient experience. But I think one of the things that and there isn't, but I think that one of the things you point out, Earl, is that the ability to be able to tell where your weaknesses are and to be able to tell what skills may need to be reinforced is something that definitely is a benefit. And I think also that when we think about simulation, we're thinking about the older version and we're not thinking about the things and the advances that have been made. And I know that with us, for sure, the students have had difficulties with clinical placements lots of times. And sometimes we can't find the ideal place for them to be for the skill set that they need. And even if you put them there, there are certain skills they may not see depending on the patients. So I think that is a wonderful thing. And it's a learning opportunity for our nurses, old and new, to see what's out there and what's available. So I'm really glad to see that as one of the trends. Another thing that was discussed, and I'm going to ask Earl to take the lead on this, was the change in the model of care in facilities, going from a patient-based care model to more of a team-based model. Can you talk a little bit about the shift in that way and also how COVID kind of made that something that we needed?
Sure, absolutely. So, I truly believe probably every generation says this, but it's never been harder to deliver care to a patient, right? And so there are several sort of forces right now that are changing the dynamics of the workforce in which we work. Right? There's certainly things like the silver tsunami, right? Lots of folks are retiring, right? Find me a hospital that doesn't have a retirement cake on the counter right today, then I'll give you $5. So I think that's happening. I think nurses, in particular nursing, needs a break, right? There's lots of nurses stepping back just because they need to, right? And then there's certainly some things playing out around maldistribution, right? Places that can afford to overpay for nursing right now are overpaying, and they're dragging people out of hospitals that otherwise wouldn't have left. But there's a financial incentive for nurses to move around. What does that mean in terms of the care delivery model? Well, the delivery model in the United States largely executes through the hands of nursing. It's certainly broader than that, but then the nurse is a 24/7 stakeholder in the care of a patient, and there are fewer of them. And the ones you have are expensive. And so I think for about a decade or so, the terms of top of licensure, let's have nursing not do the things that maybe some other allied folks can do and things like that have been in play. But the last year and a half have really forced our hand into, do we really want nursing handling the food tray when maybe we can have our nutrition partners do that sort of thing, and on, right? How many things can we talk about? And so I'm really seeing in a new way the top of licensure model play out. There's certainly been a resurgence in the LPN role as hospitals try to find a way to deliver care safely over fewer RNs, right? And so certainly I am seeing those things play out. I don't know, Anne, what your experience is. I know you're still boots on the ground in your practice, but I am certainly seeing us going back to team models and more allied help within the model than maybe we had 5-7 years ago.
Mm-hmm. And
well, Earl, I would absolutely agree with you. You know, when we look at our care models for years, at least the last 20 years or so, we've been in the primary RN model of care. And during COVID, we absolutely saw that just does not work. And we had to adopt these team models, or a hybrid team model, where we brought in other folks from other disciplines to help us care for our patients. And I agree with you. It's really time to look at how do we define the work of nursing? And nursing should not just be the RN. We have to look at what the work of the RN is about and see what those opportunities are to delegate some of those things to our LPNs, our unlicensed assisted personnel, as well as others in the healthcare disciplines, to kind of take over that. So I think right now we are in a prime position to kind of redefine what the work of nursing is about in order for us to be able to meet the needs of our patients. I agree, we are not going to be able to go back to that primary nurse model for quite a long time. We have to be able to fill the gaps in nursing caused by the shortage, and certainly have been increased due to COVID. So it's going to take us a while. And, you know, nurses who've been in practice for a long time, we knew what that team model of care was all about, because that's how we learned to work as a group to take care of our patients. But our newer nurses, those who've been only out for 20 years or so, don't know that. And I think this is a real opportunity for the more, as you said, the silver-haired group to teach others on what team model can look like and what the possibilities are around it. And we need to re-embrace the role of the LPN, unlicensed assisted personnel, and others to deliver care. Because let's face it, healthcare is a team sport, right? It's not one, discipline caring for patients. It's interdisciplinary, multidisciplinary, and we need to really embrace that in order to provide the highest quality care to our patients so that we can get the best outcomes we possibly can.
Yeah, I love the team approach. I was fortunate to be in a smaller hospital for the 10 years that I worked. It was a 180-bed facility. And so the unit that I worked on, we had sister units, women's care, pediatrics, and a med-surg unit. And so the beauty of that was that if you got floated, which, in an old connotation, the word float evokes fear in the nurse. When you get to the work and they say you're floating, you have a little crazy fit right there. But if I was floated to the peds unit, or if I was floated to med-surg, I wanted to know who I was working with, because if I had the LPN, which is Miss Jackie, and I had Miss Ruth as my CNA, we were going to have a great night, because there was that model of care that we had where we each supported each other, and it worked out well. So I think that the team approach is definitely something that's going to work well for the patients and for everybody that's on the allied team as well as us. So I'm glad to see that come forward, and I really hope that veteran nurses like you both will pass on these things, these gems of that model of care to the younger nurses that are there. This kind of segues into a little bit of what Earl was talking about, and he and I talked about briefly earlier, which is the boom that's happening with travel nursing. One of the things that, two sides of that coin I want to evaluate. First of all, why is it happening? And I know Earl can probably speak to that. And then also, even from your side, from the education side, and, are the students that are coming out of school ready to be in a place where they can immediately go travel? So maybe, Earl, you can speak to the first point, and then we'll let Anne speak to the other.
Absolutely. Happy to do it. So I think there are three sort of colliding freight trains here of issues that are leading to, certainly the ANA even went back as an all-out crisis, right? So I don't want to throw around words that sort of doomsday prep us here, but it's at crisis level, and certainly, I think there are valid groups such as the ANA who back that sort of position. And so the three freight trains, right, are one, the silver tsunami, right, which is the term that's out there, certainly in the HR literature, around what is a demographic of baby boomers who are at or near age of retirement, right? It's interesting to note that it affects all professions. It's not just a nursing thing, right? The doctors, the dentists, the plumbers, right? Everybody's aging out, and right then that was a huge sector demographic of our population, and just by the math of their age is moving up, right? So hospitals have been dealing with that maybe for the last 5 years. It will crest somewhere around 2028. It will start to decline somewhere in the early 2030s. But for the next solid decade, we're going to be dealing with not linear people exiting due to retirement, but exponential, right? Every year it's more than the year before. Up to about, early 2030s. And so that's been an impactor where hospitals have been doing a lot around succession planning. Where are we in that specific boat, right? Do we just by accident have a younger group and we're not facing it as tough? Do we by accident have an older group? And man, this is really going to be an impactor for us, right? So that's certainly one thing. I think if you fast forward into, I'll sort of mash these things together, right? A global pandemic / burnout. I think exacerbated by the fact that our wisdom was leaving, right? We have a wisdom loss as much as we had a labor loss out of our industry. Nurses were increasing in stress. How do I deal with the difficult patient, the difficult doctor, the IV I can't start? Oh my God, how do I navigate these things? Right. And so there was mounting stress. And then COVID, right? And everybody's written their own story around that. That is leading to and has led to lots of folks stepping back. It's led to lots of stress-related illness where nurses are off on FMLA and similar because they just can't do it, right? And it's not a small percentage, right? There's a large amount of nurses who are in that category, right? What that exacerbated into was then hospitals became short of staff. And started to look to the travel nurse industry to shore up their staffing. Oh my God, what about in my community if we are a COVID hotspot and I don't have the staff to execute care? And so that led to increases in price. Certainly that financial draw got the attention of lots of nurses. And so lots of nurses began to leave their perm positions on leave of absences to go take travel nurse positions and start to maneuver all around the country, chasing, what were lucrative offers for short-term assignments. And so what that sort of created was maldistribution, right? There are places who can afford those nursing salaries on contingent labor. They're certainly drawing in more nurses, creating, certainly in rural communities, less nurses who can't afford to keep up with that sort of bill rate. So again, I think sort of the silver tsunami phenomenon, certainly all of the care fatigue and burnout, and then this maldistribution issue has created a huge crisis in lots of regions of the United States.
Yeah, I definitely agree with that. And, with students and, students coming out, are there things that we need to be doing in the way of our education piece to kind of talk to them about whether they need to come out and directly go into travel nursing? What are your thoughts around that?
So, again, I am always one that sort of, I always think about sort of the positives. I don't think there's ever been a better time to come out of a nursing program. I don't think there's ever been a better time to think and consider nursing as your profession. Right now, the value of a nurse has never been greater. I'm the most disassociated CEO, CFO, name your C-suite person. The value of a nurse is planted firmly in front of them in their newspapers, on their TV shows, in the news, you name it, right? And around the country, no matter what hospital you're going to apply for, I think the nursing salaries and nursing sign-on bonus, et cetera, have never been more attractive, right? And so, down to, I thought this is an interesting conversation I was in not long ago here in my organization. Most of the benefits, if you look at it, for today's workforce in nursing is designed for someone 40 years old or older. It's a medical and a dental and a 401k and then things like that, right? Well, what's attractive to a 20-year-old coming out of nursing? I need more money. And I need to pay off these student loans. And I want to travel and see the world, and I'm young and I'm excited and that sort of thing, right? And so it's even driving how we look at, who is the demographic we're chasing for a new entry, and what does our benefits package look like? For those of us who've spent decades in nursing, and no one ever looked at us like that. We were looked at as a cost in hospitals, a necessary evil often. And boy, has the last year and a half really changed the mindset around the need of the nurse. And so that's certainly my perspective.
Yeah, it definitely has. And from the education side, would you say that the nurses are ready to step from school straight into travel?
Well, I have to say it really depends. And I agree with what Earl said. For years, nurses were thought of as a commodity, not as an asset. And I think over the past 2 years, we've started to really see a shift where healthcare organizations see nurses as a true asset. One of the things that's been really clear with COVID and with the silver tsunami that is happening is that we really need to take a look at how we onboard new graduate nurses. So I'm going to, when I talk about this, I'm talking about whether the graduate nurse goes directly into a healthcare facility to work, or if they join a travel company. It really is about how do we onboard them and get them ready through their transition to practice and make them practice ready. What this COVID pandemic has shown us is that we have to rethink that. And we need to look at ways that we're educating the newer nurse when she gets out of school into the things that they really need to practice, and really focus on the need to know, and don't worry so much about the nice to know or nuts to know in our profession. So looking at how do we make sure that they have the skills that they need? How do we make sure that they critically think and are competent? How do we actually implement nurse residency programs? So I think that there are some schools that were able to keep their nurses, in their clinical sites, and they did a really good job preparing their graduate nurses to, be able to assume positions when they graduate. I think there's others that really struggled with that because they couldn't get their students into clinical sites. So I really think it depends on the individual graduate nurse, whether or not they're ready to join a travel organization or not. I will say that the travel nurses I have worked with are absolutely top of the line, some of the best clinicians I've ever worked with, because normally they have a lot of experience, education, and that wisdom that Earl talked about. We know that a graduate nurse doesn't have all those things. So if the travel company is able to really focus on their education once they graduate around transition to practice, orientation, etc., then the graduate nurse may be ready. But if the travel organization doesn't do that, I would highly suggest that graduate nurse goes to look for a position in a healthcare organization, work for a year or two, get their experience under their belt, get their critical thinking and clinical judgment down, and all their skills, be really competent, and then go join the travel organization.
I think that's a good point. And Earl and I talked about the fact that, even with travel nursing, being able to have an educational piece that's there to support maybe areas that they may need, if those needs are made evident during the onboarding process, that makes a difference. And then the onboarding process with each facility is different, and it does make a difference with graduates where you start, because if you start at a place that's going to support and facilitate learning and give you what you need, then in a year or so you may be ready to do that. And then there are some, depending on what's happening in the schools, they may be able to come right out the gate and do that. So that's an interesting thing, and something for us to keep our eye on. I want to kind of wrap up and talk a little bit about a really big point that kind of plays into both the travel thing that we've been talking about and some of the newer innovations that are coming along, and that is staff well-being. never have nurses been as stressed as we are now, even those of us not working in direct patient care stressed. And then, facilities faced with the fact that they are losing nurses because, if I'm going to be stressed, I'd much rather be stressed for 10,000 a week than for what you all are paying me. You know what I'm saying? So there's that thing that's there too, because the money may draw people in that way. I know, Anne, that you've done some articles that talked about ways that healthcare facilities and entities can support staff well-being. Can you talk a little bit about that from your perspective, and then I'll let Earl jump in with what maybe he's done to help with staff well-being, even with his group during COVID?
Sure. So this whole idea of well-being, I think is so important. And I think healthcare organizations need to really take responsibility for it and really be able to foster well-being in their workforce. And the number one way to do that is ensure that you have adequate, competent staffing so that the nurses have a safe environment in which to practice. And if the nurse does not have a safe environment with adequate staffing or adequate PPE, you're never going to be able to build well-being. I also think that we need to really look at the mental health of nurses. And a lot of healthcare organizations have employee assistance programs. And the truth of these programs is that, in essence, they're good when you look at them on paper, but they can be very difficult to access and to actually utilize their services. I will tell you often what I hear from nurses is they tried to make appointments with a mental health professional and there were no appointments available for them. So we have to make sure these EAP programs are easy to use, easy to access. I also think that we need to have people up on the different units within a healthcare organization seeing what's really going on. So we need to get our leaders up on the floor so they know what's going on, so they can identify when there's issues. We also need to make sure that if there's moral injury or distress going on, those things are addressed immediately for the nurses. I also think that, nurses need to have time off to recharge their batteries and find the joy and the passion that they once had and realize what brought them into the profession in the first place. Also, nurses worry a lot about their financial situation, so healthcare organizations should have financial counselors available for clinicians in the workforce, as well as thinking about child care, how to support the nurse with child care. I will say no nurse's well-being has been ever improved by giving them, pizza occasionally or a water,
Hello.
Right? So
yes, can you keep the pizza? Okay.
Yeah, don't give me the pizza, but give me adequate staffing. Give me real days off when you're not calling me to say, oh, we're short. Can you please come in? Nurses, we feel bad when we hear that because we want to help out our colleagues. We need to ensure nurses have that time away from the workforce. But again, I really think the key is we need to address the staffing issue immediately because without having adequate, competent staffing and having that safe work environment, you are never going to improve workforce well-being.
Yeah, you're exactly right. Earl, what's going on with your group that you have? What have you been able to do?
Yeah, so I love Anne's comments, right? I dead on, and I certainly won't be duplicative and hit that, but yeah, I mean, I will give you a couple of anecdotes here. One, I was recently at a conference up in Boston, actually, not that long ago, in the last couple of weeks, and this topic came up around burnout and that sort of thing. And the speaker walked out on stage and so began throwing out some factoids, and he stopped and he said, "So, have you measured your own group?" Your own leadership group, right? And be the change you seek in the world, right? And so, I read a lot. My team, we talk a lot, right? Just my internal team here at Health Carousel around the concepts of burnout. But if I really stop to go look at and implement the measures that that were just mentioned around all of the dimensions of someone's health, right? Do you have financial literacy? Do you need help there, right? Where are you distressed? And how can we help? And so it starts with us, right? And then so are we measuring? And despite all of the discussion around it, even internally in my organization, I really didn't objectively know. I didn't objectively know where I stood on with my own team. right? And so we've really embarked on a journey around a couple of things, right? And so, Anne certainly identifies this, but it's about identification, right? How is the relationship with your mate, with substances, right? Is it too much nicotine? Are you drinking too much alcohol? How's the relationship with your God? How's your relationship with your kids? How's your, are you even able to identify that you're off course? Right? Because that stuff drips onto others and perpetuates a bad environment where you may not even know you've had insomnia for 3 months now, and man, you're in full blown burnout, and you're dripping negativity and part of the problem, and you may not even know. Right. And so I think identification has a lot to do with this here. And certainly that's not lost on me. I'm certainly doing lots around that right here at home. Right. I can affect my own team. And so that in the last couple of weeks has hit me hard, and something that I'm certainly taking away from it.
And I love that. And I love that Anne mentioned being visible, because two of the nursing leaders I think about the most, one was Van Hunt, who also worked down at Grady in Atlanta for some years. And the other is the nursing director that was at Miss Ann, that was at the the hospital I first started with. And one thing I like about both of them was that they walked the floor. You would see Miss Ann on the floor at least once during your shift. And, even if it was in the morning for night, she's come in, and Van walked the floor as well. So if someone was not well, they had a feel for what you looked like when you were well, so that was good. And I know in some organizations, depending on how large they are, that's not physically possible. But I do know, Earl, that you've done some great videos that I got to watch to encourage your staff, even with a video, to let them know that you were thinking about them. So I think that you're practicing what you've been preaching. So that's amazing. So I'm going to wrap up with you two. And this is a little bit different, because I'm going to wrap up with what I usually begin with everybody else. But just in a quick little mention, I'm always curious to know, how did you end up being a nurse?
Ladies first, Anne, if you want to go, I would love to hear your story.
Well, so I became a nurse. I kind of always knew I wanted to be a nurse, but I also wanted to be a teacher. When I was 12 years old, my father had died of leukemia, and at that point, I heard stories about how supportive the nurses were at that time, and was able to see it, and that just meant so much to me. And I always thought I really wanted to care for people in need, but I also wanted to teach. And so, that's kind of, I became a nurse. I worked in med-surg for a very short time, until I realized I really loved critical care, and that's where my passion laid. And then I switched over to critical care. But it was just this overwhelming knowledge that I had, or a calling, that I wanted to be a nurse. But it all came from the fact that I was able to see what nurses did in caring for my father, and I wanted to do that as well.
That's amazing. And you got to be a nurse and a teacher, so you got both dreams. Okay, Earl, how about you?
Yeah, my path was a little different. So I'm from northeastern Canada, right on the ocean, in a small place called Newfoundland. And if you've ever seen the show The Deadliest Catch, that kind of work, that's what my family does. Wow. That's all of my family's history. And that's what I should be doing by all accounts. In the early 90s, it turns out that the industrial fishing mechanism got so good that the government shut down the fishery, and that could no longer be a source of income. And I was a young college age boy. And they were like, so if you sell back your fisherman's license, we'll give you a free college education. Wow. And so all of the boys, certainly of that time, all ran back to college. And I was good at chemistry, so I was like, I'm going to be a pharmacist. This is going to be great. And I failed pharmacy so bad that I don't even think they wrote grades down on my transcript. But I really enjoyed the sort of clinical pieces and got a chance to be in hospitals. And this was so different than being, out at 200 miles off the coast of Newfoundland, which is about where the Titanic went down. Yeah, I really enjoyed hospitals. I needed to do something different, and so I was like, I think I'm going to apply to nursing, and got into the program, and it has been such a blessing. It was clearly my calling. I have enjoyed every second of my 25 years. It has taken me all over the world and into what I'm doing today, and I get a chance to talk to nice folks like you. And I just never ever thought that would be my path, and so I feel incredibly blessed through that journey.
Well, that is amazing. I've been incredibly blessed by both of you joining us today. It always amazes me how smart, how caring, how innovative, how wonderful it is to have conversations with fellow nurses. I appreciate both of you and the work that you're doing. And I will tell you that even though COVID right now has darkened kind of the horizon, there's always hope. There's always a light out there. So I want to thank you both for joining me and for being a part of that light for me and for other nurses today.
Well, thank you.
All right. Take care.